the spectrum of microbial keratitis, a recent update.
Good morning everyone. Today my topic is, my name is Dr. Jani Basha. I am from Keratitis, Vijayawada. The spectrum of microbial keratitis. All of us know epithelial defect of cornea associated with inflammation, either infective or non-infective, is considered as a corneal ulcer. The etiological, epidemiological patterns of corneal ulcer found vary with patient population, health of the cornea, geographical location, and climate, and also vary with over the time. Understanding the epidemiological features, risk factors, and etiological agents that occur in specific region are important in rapid recognition and timely institution therapy, optimal management, and prevention of the disease. This ocular trauma and corneal ulcers are significantly causes monocular blindness around 1.5 to 2 millions in every year. In developing countries like India, corneal ulcer is recognized as a silent epidemic. Many of the cases, with neglected cases, whether corneal ulcers may end up with corneal perforations, endophthalmitis, and phthisis. 60 to 70% of these corneal ulcers may land up with corneal ulcer, corneal scar, or adherent glaucomas. We did one study in Keratitis. It is 1 year of duration. This is a multi-centered retrospective study. The patient referred to the cornea clinic that diagnosed as a microbial keratitis. What are the inclusion and exclusion criteria? Inclusion criteria: all infiltrates greater than 2 mm size, all age groups, all cases were scraped. But exclusion criteria is less than 2 mm ulcers, viral and immune are excluded, and also healed corneal ulcers. Data was analyzed based on demographic patterns like gender, age, residence, and occupation, and also identified the predisposing factors like ocular injuries, usage of steroids, coexisting ocular diseases, and systemic diseases. Then identify the various organisms by doing appropriate microbiological investigations of scraped material. We took detailed history of patient age, sex, occupation, and economic status, and predisposing factors, and also we took systemic illness and also usage of topical medications and nature medications. We took detailed ophthalmological examination also. Based on the clinical severity, we consider as a severe and non-severe based on this infiltration area 6 mm and superficial or two-thirds of superficial infiltration, and depth of the ulcer superficial 1/3 we consider as a non-severe, and other taken as a severe cases. Detailed lab investigations was done. The management diagnosed cases microbial keratitis was managed specifically with antimicrobial therapy based on smear and culture reports. That follow-up was discretion based on clinician. The observations, we took 100 cases based on this study. Sex incidents in our study, most of the 100 cases, 75% of the male population was identified as presented as microbial keratitis when compared to the females. And also living conditions, when compared to urban population, rural populations people are more affected. In occupation, when compared to other, most of the people affected with microbial keratitis are more of farmers. And also in our study, the predisposing factor is mostly injury with vegetative matter when compared to other. The age of incidence, most of the people affected with mean age is 41 to 60 years of age is more affected when compared to other age groups. In our study, most of the organisms isolated was fungi is more common when compared to bacteria and protozoa and other. These are the various organisms isolated in 100 cases. Most of the cases were fungi, where different species are also identified. These are beautiful pictures we taken from our culture reports. There are aspergillus species and also cladosporium and non-sporulating microorganisms and also acronymium. This is aspergillus flavus. This is the more common. And also the bacterial smear, the streptococci and staphylococci. And also that ocular associations like blepharitis and dry eye myobomitis, they are not significantly, they are statistically not significant in our study. And also systemic associations, diabetic and hypertensive also not associated. The follow-up in most of in 100 cases, 87% of the cases was resolved with antimicrobial therapy. Only 13 cases and 13% was underwent for therapeutic keratoplasty. According to our descriptive analysis, we conclude that the following factors are significantly associated with microbial keratitis: the male, median age group, rural population, agriculture farmers in harvesting season, injury with vegetative matter, and most of the cases were fungal etiology. Thank you.
How many cases you got culture positive?
Culture, most of the cases are, we took 100 cases. There are also, all cases are culture positive. All are culture positive.
Fungal as well as bacterial.
Fungal as well as bacteria.
Which fungus most?
Most aspergillus flavus is more common.
Thank you.
Yeah, thank you, madam.
Next topic is by Dr. Hasika. Recent updates in acanthamoeba keratitis.
Yes. Good morning, one and all. So I'm Hasika, and I'm going to talk on acanthamoeba keratitis. I have no financial interests. And yes, acanthamoeba keratitis can be a challenging infection for several reasons, but the two most important ones is, first, the parasite. The parasite has two forms. The first one we don't have to be worried about. It's the trophozoite. It's very fragile, so it's very easy to treat. But the dormant cyst is very resistant to almost all the antimicrobial drugs and is responsible for the persistent disease. Yet the acanthamoeba multiplies by binary fission. That means one acanthamoeba can become 2, 2 can become 4, 4, 16 in a sort of a geometrical multiplication. The second point for the challenge is delay in diagnosis. Think of it. If you have a patient wearing contact lens with any kind of symptoms, think about acanthamoeba keratitis. The sooner, the better. If you have a diagnosis delayed, the parasites will penetrate deep into the corneal stroma and successful therapy becomes exceedingly difficult. Early diagnosis and treatment, anywhere less than 3 weeks, is the only way to have a good prognosis with this disease. And in the early stage, do not think about herpes keratitis alone. Acanthamoeba can give this branchy patterns as pseudodendrites, so be aware of it. In relation to the use of contact lens, the prevalence is much higher with soft lenses in comparison to the rigid lenses. But we also see in patients with scleral contact lens because it's very difficult to take care of these lenses. Risk factors, we all know that poor lens hygiene and exposure to potentially contaminated solutions is an important risk factor. But be aware of large bottles of saline solutions because they can get contaminated by acanthamoeba. And symptoms, patients have severe pain in this disease and it's often disproportionate to the clinical signs. Coming to the clinical findings on biomicroscopy, if you have early stage of the disease, you will see much marked punctate keratitis and perineural infiltrates. In the late stage, you see epithelial loss and ring infiltrates. And limbitis, that is peculiar of acanthamoeba keratitis, we can see in all the stages of the disease. So we have some pictures here to remember. The punctate keratitis can be diffuse or localized over stromal corneal infiltration. And the dendritiform ulcer, where you can see a linear configuration which resembles the epithelial form of a herpes simplex keratitis. Here you can see early epithelial stage. Note the granular cystic appearing epithelium with little or no stromal inflammation. And in the second one, you can notice elevated areas of epithelial irregularity and marked radial perineuritis, a finding which is highly suggestive of acanthamoeba keratitis. The perineural infiltrates, a very important finding, are usually seen during the first 4 weeks of the infection and are pathognomic. They occur due to clustering of the acanthamoeba trophozoites around the corneal stromal nerves, resulting in the swelling of the nerves. And these trophozoites kill the nerve cells by direct cytolysis and apoptosis, causing severe pain experienced in acanthamoeba. Late disease, that is after 1 month, is characterized by ring infiltrates, frank ulceration, and sometimes even stromal corneal melts and perforation. Ring infiltrates, they're usually central, but once in a while we can get these paracentral ring infiltrates. They can be even a semi-ring, they don't have to be a complete ring. And this is a classic ring infiltrate of acanthamoeba. You can see the hypopion and conjunctival congestion here. Late stages of acanthamoeba can cause corneal thinning and even perforation. Maybe you have to glue these cases and keep treating them. Hypopion usually in very severe cases can be very exuberant. And limbitis, like I said before, can be seen in early as well as advanced stages of this disease. Since acanthamoeba keratitis is often misdiagnosed, it will be important to be familiar with the clinical scenario wherein to suspect acanthamoeba etiology. So suspect acanthamoeba keratitis when patients presents with inflamed corneal nerves, or patients with chronic keratitis with ring infiltrates not responding to any therapy, patients with ulcerative keratitis usually for prolonged duration not responding to antibacterial or antifungal therapy, and patients with suspected HSV keratitis not responding to anti-HSV therapy. All these patients must be subjected to laboratory tests for establishing the diagnosis. Diagnosis, we have several tools. On smears, we can use Graham's, Giemsa, or Calcofluor White to enhance the visibility of parasite. The acanthamoeba cyst can be seen as a double wall structure with inner wall being hexagonal in shape. It's cultured on non-nutrient agar with E. coli overlay. Clear wavy tracks on the culture plates are seen as shown here. These clear tracks suggest the migrating trophozoites that feed on the bacteria, and you can see the trophozoites visible at the ends of the tracks. PCR is an excellent tool but of little use in a daily practice. In vivo confocal microscopy, extremely useful tool to detect the cysts. They appear as well-defined round double-walled hyperreflective bodies. So in confocal microscopy, we start from the level of endothelium and we come forward. As we come forward, we get to see these thickened nerves, inflamed nerves, and that is the reason we see the perineural infiltrates. And the double-wall cysts, the cysts you see here, these are the double-wall cysts. And then we see the refractile trophozoites at the basal epithelium of the cornea. Patients with deep infiltrates and negative corneal scrapings might need corneal biopsy. And about treatment, the goal is to get rid of acanthamoeba as soon as possible and eventually to suppress the inflammatory response. So normally 2 classes of drugs are used, biguanides and diamidines. There are several protocols to treat acanthamoeba. Neomycin is no longer used. The protocol that is used routinely is a combination of PHMB and propamidine intensively. However, there is some newer research to suggest that PHMB 0.08% monotherapy is as effective as a combination of PHMB 0.02 with propanidine 0.1%. Early intensive treatment is thought to be more effective as cysts have not yet had the opportunity to mature fully. So medications are initially given on an hourly basis, both day and night for the first 48 hours, then reduced to only hourly during the daytime for a period of days to weeks. As the infection subsides, the frequency may be reduced to 4 times a day, a regimen which is maintained for 6 months to a year. However, toxicity is a big issue. We cannot introduce another complication to such a weird infection, so how do we treat toxicity? You just stop all the medication. Acanthamoeba is not an explosive infection, so you just stop everything, and if you see that the case continues to improve, you just make the diagnosis of ocular toxicity. But if there is an active infection with clinical signs and positive cultures, you can switch to or start a low toxicity agent like PHMB. And azoles, only newer generation azoles like voriconazole and posaconazole appear to achieve cysticidal effects in vitro. Meltifosine is a newer anti-amoeba drug that has recently obtained FDA approval for the treatment of acanthamoeba keratitis. Early case reports support the use of meltifosine as an adjuvant treatment for refractory cases of acanthamoeba keratitis. However, further studies are warranted to understand the optimal timing, dosage, and route of administration. A relation to topical corticosteroids, they should be avoided in the first few weeks of disease. This is because there is a potential risk of promoting encystment and increasing the number of trophozoites. But if there is a persistent anterior segment inflammation and pain, you can use corticosteroids always after 2 weeks of a specific anti-amoebic therapy. And one should not prescribe steroids without concurrent administration of anti-amoebics. One word on keratoplasty. Usually it is worse prognosis for therapeutic grafts, but it's a controversial issue. When possible, keratoplasty should be delayed as the eye is uninflamed and acanthamoeba is cured. Complications, several in post-therapeutic grafts, but the worst one is recurrence of the infection in the graft. However, DALC has been shown to be associated with better prognosis, both for eradicating as well as graft survival. So in summary, think of acanthamoeba in all the patients wearing contact lens with any kind of symptoms. Can be difficult to treat, mainly if the patient has more than 2 weeks of symptoms. It's a disease that you have to medically treat. When possible, delay the therapeutic grafts. Thank you. Thank you.
It is a disease of suspicion, as you told.
Yes, ma'am.
When patients present to us, he will be going to so many doctors and
Yes,
with so many treatments.
Yes, ma'am.
Even with ring ulcer, sometimes we cannot appreciate
Yes, ma'am.
neural factor.
Yes, ma'am.
Peripheral neuritis will not be there. We have to scrape and see.
Exactly, ma'am.
KOH mount also. we
KOH
can
mount
see,
also will help a lot.
Sometimes mixed infection will be there along with fungal infection.
Yes, that's a possibility. Yes,
Thank you.
ma'am. Thank
One
you
more
so much.
treatment is when we can try cyclohexidine also.
Yes, ma'am.
Chlorhexidine.
Chlorhexidine.
Thank you, ma'am. Thank you. Dr. Raghava, update on viral hepatitis. Dr. Raghava, not there, I think. Oh, sorry.
Good morning, everyone. Today I'm going to discuss about HSV keratitis, various clinical manifestations. I'll take you through a case where so many manifestations are there. A 50-year-old male came with the chief complaint of pain, redness, watering, and blurred vision since 5 days. In this case, in this picture, you can see there's a conjunctival congestion, corneal nebular scar, and dendritic lesions. If you zoom it, you can see the dendritic lesions clearly. So the diagnosis is HSV dendritic keratitis. So what are various epithelial manifestations of HSV keratitis? So various epithelial manifestations are first vesicular form. Vesicles unite to form a dendritic lesion, and after dendritic, then geographic lesion, and there can be a neurotrophic ulcer and marginal keratitis. So coming to the dendritic lesion, the characteristic features are they are raised lesions and with branching linear shape, and large terminal bulbs will be there with swollen epithelial borders. They take stain, whereas you have to differentiate this from pseudodendrite. Earlier speaker Dr. Hasika said pseudodendrites will see in acanthamoeba keratitis, etc. So here the margins are not rounded and not elevated, and the bulbous aspect of the branching dendrites will not be seen. Will be seen in regenerating epithelium and fungal or amoebic infections, and during drug toxicity also. So next one, after dendritic lesion, then another variety of epithelial keratitis, geographic epithelial keratitis. So what is the characteristic features of geographic ulcer? So if you not treat dendritic lesion properly, or if you treat dendritic lesion with steroids, then that can lead to geographic ulcer. You can see the ulcer epithelial defect will not match with the underlying epithelium, and they will have irregular margins and scalloped margins. These are the differentiating features. Whereas if you take, you have to differentiate it from persistent epithelial defect or a neurotrophic ulcer, because the entire treatment plan will be different. Here it is due to the active virus, whereas in case of neurotrophic ulcer it is due to the denervation. Right. Then next one is neurotrophic ulcer. Here you can see the persistent epithelial defect. The location is important. It is usually occurs in the interpalpebral area or inferiorly. Shape also is important. Usually they are regular, round or oval in shape, whereas the earlier picture we seen the geographic ulcer where shape is not regular. So how to differentiate between geographic ulcer and persistent epithelial defect is that one, the shape, margins and the location. Here you can see elevated and smooth borders, and thickened and rolled edges will be seen. If you not treat properly, again they will lead to melting and perforation. So the last epithelial form is HSV marginal keratitis, where it is a lesion occurs close to the limbus and there will be an AP defect, and vascularization will be seen and associated with infiltrate. So this is the only epithelial keratitis form where we have to use steroids along with antivirals. Remaining all epithelial lesions we should not use steroids, only antivirals. So coming to our case, so this is epithelial dendritic keratitis. Again, the same case, if you see closely, there is a stromal edema, again some cellular reaction. So what is the diagnosis again? So again, stromal lesions, stromal classification is immune stromal keratitis and necrotizing stromal keratitis. So how to differentiate between these two, immune and non-immune? So if a stromal infiltrate in a HSV keratitis, if there is a stromal infiltrate and if it is associated with AP defect, it is necrotizing stromal keratitis, and if the AP defect is not there, it is non-necrotizing or immune stromal keratitis. So what are classical features of immune stromal keratitis? Usually cellular reaction will be seen in the stroma, can be diffuse or focal or multifocal. A location can be central or paracentral. In this picture we can see the immune ring or Wesley ring, where the dense cellular reaction is seen and the infiltrate clay is usually sterile. It can be complete or incomplete. It can have single or multiple lesions, and it is a type 3 hypersensitivity reaction. So how this should be differentiated from HSV stromal necrotizing keratitis. As earlier said, epithelial defect will be there and dense leukocytic infiltration will be seen. And because of this dense leukocytic infiltration, that can lead to necrosis and collagenolisis, and further lead to corneal melting and can lead to perforation. Along with that, classical features of stromal keratitis are deep vessels, old scars and history of recurrences. So we have to differentiate this necrotizing stromal keratitis from other infections like bacterial, fungal. So classical feature is epithelial defect. Epithelial defect will not correlate with the underlying infiltrate. That's the classical feature. Whereas in a bacterial or fungal keratitis, usually the epithelial defect will correlate with the underlying infiltrate. So coming to our case, earlier we have diagnosed it as epithelial dendritic keratitis. Now there is stromal keratitis, and that is immune stromal keratitis also. Again, if you see closely, there are some old and fresh KPs, cells are there, and you can see the posterior synechiae. Again, coming to the endothelial keratitis. So various forms are disciform keratitis or local endothelitis. Other form is diffuse endothelitis and linear endothelitis. So I have not seen linear endothelitis, but I have seen disciform and diffuse endothelitis. So coming to the diffuse disciform endothelitis or focal endothelitis, here how to differentiate again between endothelitis and stromal keratitis. So in stromal keratitis, usually you will see infiltrate or cellular reaction, whereas in a case of HSV endothelitis, only edema, frank edema will be there. So here in this picture, the foci of the endothelium is affected, and KPs will be there on the foci of endothelium, and the overlying there will be stromal edema or DM folds. It can be associated with trabeculitis and can lead to increased IOP. This is again a classical, this is a picture of disciform endothelitis or focal endothelitis, where the focal area endothelium is affected and overlying there is an edema. In the next picture you can see, so the same, the next picture we can see the infiltration in the stroma. So again this will go into the immune stromal keratitis, and this is not endothelitis. It can be associated with endothelitis, but primarily it is stromal immune keratitis. In diffuse endothelitis, there will be diffuse pigments on endothelium, and it can be associated with iritis. In this picture you can see the dense AC reaction with hypopyon. This is a diffuse endothelitis with how to differentiate between a normal uveitis with these endothelitis pictures. In uveitis, usually you will see KPs in the Alt's triangle, and edema is not that frequent. But here in these cases, HSV endothelitis, edema will be there, and diffuse pigmentation will be there, and increased IOP is will be there. And diffuse endothelitis should be differentiated from Fuchs endothelitis or Fuchs heterochromic iridocyclitis, where there will not be posterior synechiae and IOP spike will not be that common. Here in this picture you can see diffuse KPs with severe anterior chamber reaction, and there is associated segmental iris atrophy also there with increased IOP. Coming to our case, the diagnosis is epithelial dendritic keratitis with immune stromal keratitis and diffuse endothelitis and HSV iridocyclitis. So, whereas treatment protocols are in HSV epithelial keratitis, we can give topical antivirals like acyclovir or systemic antivirals. I prefer in this epithelial keratitis, topical should be fine. Whereas in a case of stromal immune keratitis, again, here the main problem is the immune reaction, so topical steroids play the main role and the antiviral role is questionable, and antiviral role mainly in the prophylactic thing. You have to prevent recurrences, even according to head study, it is to prevent recurrences, we have to use antivirals. Whereas in case of stromal necrotizing keratitis, we can give topical as well as systemic antivirals, but I prefer to give systemic antivirals in case of stromal necrotizing keratitis, and we have to address the thinning and secondary infections also, and along with that we have to give topical steroids. In endothelial keratitis, my preferred treatment mostly will be systemic antivirals only. There is no role of topical antivirals in uveitis and endothelitis. So, along with this topical steroids, if a dense anterior chamber reaction is there, we can consider systemic steroids also. Thank you. So, my take home message is HSV keratitis can affect all the layers of the cornea. Thank you.
Dr. Raghava, for your elaborative talk. Sometimes we can see endothelitis in post HSV scar PKPs. We may get confused with whether it is graft rejection and the chorda dust line or viral endothelitis.
Yeah.
If it is from the host side, it could be the reactivation of virus.
Yeah.
If it is towards the graft side, it is chorda dust line.
Right.
Thank you.
Thank you. Thank you.
Good morning, everyone. Right, we'll have a quick look at pythium keratitis here today. I have no financial disclosures. So what is this pythium? It is an oomycete or a parafungus, as we know. It does bear some resemblance with fungal keratitis morphologically, but there are certain differences in that it lacks ergosterol in the cytoplasmic membrane, due to which the antifungals are ineffective, and there is a presence of cellulose in its cell wall. Human pithiosis can be either systemic or ocular. Systemic forms occur in individuals with underlying hematological disorders, whereas ocular forms occur in healthy individuals. At the end of this lecture, we should be able to answer these few questions. That is, what are the clues to clinically suspecting a pythium keratitis, because it does look like a fungal keratitis clinically as well. What are the methods of definitively diagnosing this entity, and how do we treat it? Coming to the clues to clinical suspicion, as we know, a tentacular pattern is one of the characteristic features of a pythium keratitis. As depicted by the yellow arrows, if you see fine lines radiating from the infiltrate towards the limbus, it is called a tentacular pattern. This is a closer view of the tentacular pattern, where we can see large lines extending from the infiltrate, which is in the inferior 1/3, towards the limbus. The second feature is the presence of dots surrounding the infiltrate. Thirdly, a peripheral guttering or a furrowing or thinning, which is similar to a peripheral ulcerative keratitis pattern, is one of the clinical signs that suggests a pythium instead of a fungal keratitis. Lastly, we have reticular or a lace-like or network-like pattern, which again suggests a pythium keratitis. So these are the clinical clues. There is also a scoring system that has been devised, put forth by Chatterjee et al., which is given 1 point each for the presence of tentacles, dots, reticles and gutters, as we have discussed, and ring infiltrate as well. In the presence of 2 or more in your keratitis case makes the possibility of a false positive diagnosis very less, that is the order of 1.4%. Coming to the diagnosis, as in any other keratitis, we would have to depend upon stains and cultures and PCR when available, but there is something called zoospore formation as well, which we shall be discussing. There are multiple stains which can be used, but the most commonly used ones are the grams and the KOH mount, and the sensitivities have been mentioned against each of the staining procedures. So even in stains, there are certain features that distinguish a pythium filament from a fungal filament. That is, pythium filaments are described as being broader, longer, aseptate or relatively sparsely septate, and also they are folded upon themselves like ribbons as shown by the yellow arrows on the picture on the right. In addition, the presence of vesicles or vesicle-like structures within the filament also would suggest a pythium against a fungal keratitis. These are the KOH calcofluor white stain pictures, again showing ribbon-like foldings by the red arrows here and vesicles inside the hyphae as shown by the yellow arrow. Trypan blue, which is easily available in the OT, also can be used for the staining of this particular organism. And then there was this novel staining technique which was put forth. It is the iodine potassium iodide sulfuric acid stain, which is thought to be very simple, sensitive and specific. In this picture, using the IKI H2SO4 staining, the three pictures on the top show the blue-black color. These are of the pythium filaments. Because of the presence of the cellulose in the cell wall, which reacts with the H2SO4 and the potassium iodide to turn blue-black, these have stained blue-black. Whereas the fungal filaments in the bottom three pictures do not contain cellulose in their cell wall, and hence they do not react with the IKI reagent, and there is no blue-black color. So this is one simple, sensitive and specific test for pythium filaments. Culture also has a characteristic description, that is the colonies on blood agar are relatively flat with feather-like edges. They are incompletely submerged and are glabrous. Glabrous means smooth, and the color is either colorless or light brown, and they are not easy to scrape. Then comes the zoospore formation. These zoospores are the asexual spores which can be demonstrated in the laboratory. So in this particular video we can see the demonstration of the motile zoospores were released from the sporangiophores. So till here, that is the staining culture in the zoospores can only allow us to suspect pythium, but if you have to diagnose it definitively, you have to depend upon polymerase chain reaction. The DNA sequencing of the internal transcribed spacer region of its DNA is the only confirmatory test which can diagnose this particular entity. There is also a novel duplex polymerase chain reaction which is much faster, and it can give us results in 5 to 6 hours. Serology has no role. In the histopathology, the Gomorrhe's methanamine silver and the potassium iodide sulfuric acid stain are supposed to stain the pythium filament very well. With hematoxylin eosin, there is a pale pink color, hence we cannot distinguish a pythium filament, whereas with periodic acid shift, there is very poor staining. This is a recent publication where they have shown the differences between the pythium and the fungal filaments. If you take a close look at the fungal filaments, you can find the septae here, whereas in the pythium filaments, they are relatively aseptate. The Gomorrhe's methanamine silver stains both the organisms up to the same degree, and they stain both of them very well. In periodic acid shift, the pythium is not picked up, whereas the fungus is picked up very clearly. Similarly, the opposite is true with respect to the IKI H2SO4 stain, which picks up the pythium but not the fungal filament. In vivo confocal microscopy can help us detect the filaments, but they cannot distinguish between a pythium and a fungal filament. Coming to the treatment, we have medical and surgical variants. In the medical management, initially this disease was thought to be a surgical entity alone, whereas this case report came in where they said there was a successful management using linezolid and azithromycin. Then came this particular paper which said that rates of TPK reduced when this topical linezolid and oral azithromycin were used. This eventually came to be known as the anti-pythium therapy, or the triple regimen, which consists of topical linezolid, topical azithromycin and oral azithromycin as shown. There are also other reports using various drugs like linezolid, minocycline and chloramphenicol. This recent randomized control trial said that the combination using linezolid and azithromycin was much superior to linezolid monotherapy alone, which means if you have an access to both the drugs, always use both the drugs and not linezolid monotherapy. Other drugs also have been used, which include mupirocin and other tetracyclines as shown. Multiple reports have shown that surgery is the only way out in pythium keratitis, but all these reports came before the advent of the triple therapy put forth by Bagga et al. From L.V. Prasad Institute. Surgical management would include a large TPK with adjunctive measures like cryotherapy and absolute alcohol, evisceration in non-resolving endophthalmitis and enucleation in panophthalmitis cases. Intracameral intravitreal injections also can be used as well as tissue adhesives with BCL. Adjunctive treatment usually includes cryotherapy to the host bed or absolute alcohol soaked in sponges and applied to the sclera so that recurrences are prevented. Topical ethanol also has been shown to be effective in pythium keratitis, but its concentration is not very clear. This is a recently proposed algorithm which says for small infiltrates you go ahead with medical management, and for infiltrates between 4 and 6 millimeters you use both medical management, and if it worsens you can try ethanol. Whereas in infiltrates greater than 6 mm you directly use both medical management and topical ethanol. Whereas those involving the limbus you have to use a therapeutic penetrating keratoplasty with surgical adjuncts as mentioned. Then there is this particular organism which is another oomycete, the Laginidium, which can present absolutely similar to Pythium keratitis, and PCR is the only way we can distinguish between the two, and this has an even worse prognosis when compared to Pythium keratitis. Then there are areas of further research. This paper showing scanning electron microscopic pictures wherein Pythium filaments treated with xanthellitine, Pseudomonas extract and Klebsiella extract were effective in vitro to destroy the Pythium filament. Multiple other drugs have been used as mentioned. Then coming back to our initial 3 questions, the clues to clinical suspicion: the combination of presence of tentacle-like lesions or dot-like lesions and no response to antifungal treatment should alert one to consider the infection by Pythium. Similarly, the presence of a reticular pattern, dots, tentacles or peripheral guttering should alert the clinician to the possibility of Pythium. Whereas feathery and hyphate margins and endothelial plaques are equivocal and can suggest fungal keratitis as well. Coming to the methods of definitive diagnosis, as I said, there are characteristic features, but only PCR is diagnostic. Lastly, it is treatable and has shown good response to medical treatment with linezolid, and there is a recommendation that for mild to moderate cases you use topical antipythium therapy, whereas for severe cases you need to use a therapeutic grafting, preferably with cryotherapy and absolute alcohol.
Thank you, Dr. Ramya. Nowadays, Pythium cases are increasing. Initially, we feel as if as a fungal keratitis. Only after refractory period only we have to re-scrape and then diagnose Pythium. Thank you. Dr. Somaselamurthy madam is not there, I think. Dr. Arvind Roy, Dr. Veena. Infection, rejection and the connection. Dr. Nishat Hussain and Dr.
Okay. So post PKP infectious keratitis is a challenging situation where we need to maintain the graft clarity, and at the same time we need to treat the infection. So I am Dr. Veena. I am going to speak about infection, rejection and connection. So here it carries a high risk of serious complications such as graft rejection and failure, and less commonly endophthalmitis. Topical corticosteroids used in post PK infectious keratitis may act as a double-edged sword, particularly in fungal infection. So it is different from the standard infectious keratitis. PK-IK is different from the standard IK. Firstly, it occurs in a graft that can result in potentially devastating complications like graft rejection, failure and endophthalmitis. Secondly, topical corticosteroids are often required to reduce the risk of graft rejection. However, in the event of infection in the post-keratoplastic graft, so the use of corticosteroids may act as a double-edged sword, as it can worsen the infection during the acute phase. So these are the studies conducted worldwide. So the summary of post-keratoplasty infectious keratitis based on large case studies, more than 500 cases in order of chronology was given. So here the incidence of PKIK is, in developing countries it is 9.2 to 11%, in developing countries more than developed countries. Common risk factors are use of topical corticosteroids, it will come around 72% of times. The reinfection is, or infection in the post PK is due to use of topical corticosteroids. Suture related problems are broken sutures after 1 year or 2 years. These can cause, or loosened sutures can cause infection, and dry eyes, ocular surface diseases, previous corneal infection. So Most commonly this infection happens in after PKP and DALK due to ocular surface. Most common organism is from the ocular surface commensals, particularly gram-positive bacteria. EK is usually caused by Candida species. So coming to the incidence, a large retrospective cohort studies of 2000 cases keratoplasty performed between 2007 to 2018 in US. The incidence is 5.9 to 1.3% following PKP and EK. The higher proportion of infection occurring in PKP is 93% compared to DALK and EK. So risk factors here is prolonged use of corticosteroids is the topmost risk factor, and second is sutures. That's why most commonly it is in the PK and DALK. And indications for surgery means if it is a therapeutic cause, then the chances of reinfection in the graft is more common, and ocular surface disease like dry eye, neurotropic keratitis, all those conditions will come. Coming to the topical steroids, majority studies are found topical corticosteroids are the main contributing factor, primarily attributed to its local immunosuppressive effect. So it is in US and Australia and UK and so many studies were conducted. So it is around more than 80% of times the cause of the reinfection infection in the graft is topical corticosteroids. Here we are seeing in the picture A, the causative organism is Streptococcus pneumoniae, and here after Descemet's endothelial keratoplasty, and patient is on topical steroids. And picture B, if we are seeing, it is related to the suture related infection. Most common organism is Staphylococcus aureus or Streptococcus. And in C and D, we are able to see here it is the Pseudomonas aeruginosa that is causing the infection in the failed Descemet stripping endothelial keratoplasty, and E and F here Moraxella cataralis. So suture related problems are late occurrence of PIK because of the loose or broken sutures. Suture complications mainly because of the corneal dehydration and incomplete epithelialization over the suture material or suture degeneration and cheese wiring, especially in the post keratoconus where the cornea thickness is very less, that will cause the cheese wiring because of the pressure. And suture related problems generally occur either within 1 year to 30 months in between. So, and another third cause is previous history of infectious keratitis, those who underwent therapeutic keratoplasty. So here it is very high post PKIK is very high in these therapeutic cases. It is around 6 to 41%. Most commonly in the fungal keratitis and acanthamoeba keratitis, we will see reinfection. So, so recurrence of HSK keratitis also another, one of the other thing we need to consider while treating these cases. So, fourth condition is ocular surface diseases. It is dry eye is the most common cause because of the prolonged steroids, and in PK and DALK corneal sensations may not come back over a period of 1 year, or sometimes it may not fully come. So that is the reason cause for dryness. Dry eyes, blepharitis, persistent epithelial defect, neurotropic keratitis, trichiasis, exposure keratopathy and bullous keratopathy. These are the common conditions that can invite the infection after PK. So causative organisms, coming to the bacteria, fungus and viruses. Most common bacteria are the common commensals of the ocular surface. They are gram positive. Majority of the organisms are 82% of the times gram positive. Staphylococcus aureus, Streptococcus pneumoniae, and epidermidis, something like epidermidis. And coming to the fungus, most commonly Candida is the most common organism that will come in the graft, and less common Fusarium and Aspergillum species. Rare common is Cryptococcus. Viruses, herpes simplex keratitis, it is the most important PKIK infection, although accounting to 7% of microbial causes. HSV should be considered as a diagnosis in case of non-resolving epithelial defect following keratoplasty. So recently in East Asia, cytomegalovirus infection also reported. It is area specific. It is not reported in every area, but it is published in the East Asia. Coming to the diagnosis, it is like a common, we have to go with the corneal scrapings, microscopy, culture and sensitivity. Suture related cases, we have to remove the suture material and send for microbiological culture. So in Adler's et al., they evaluated the presence of microbial growth or biofilm formation among his corneal sutures removed following astigmatic correction, loosening of or breakage of the infection. Biofilms are the composed of extracellular matrix secreted by microorganisms and are usually resistant to conventional antimicrobial treatment. Coming to the diagnosis, so we have to do confocal, because in confocal microscopy it is very much useful determining the fungal keratitis and acanthamoeba keratitis. And anterior segment OCT, now it is available in every hospital. It provides a quantitative and objective measurements. So here characteristic patterns, we can, it will help us to identify the characteristic pattern, depth of the infection and monitor the progression of the infection and treatment response, especially deep-seated infections. So here in the anterior segment OCT, here following Descemet stripping automated keratitis, inferiorly, so there is infiltrate. So in the OCT also it is showing, after treatment it is very much cleared. So anterior segment OCT will be helpful to monitor the progression of the treatment strategy is type of the microorganism, severity and location, and type of the keratoplasty, and clinician's experience and preferences. So this is the chart, how to proceed with the management, medical management and surgical management. So medical management, mainly we can start with the topical steroids, and if it is good response is there, we can continue the treatment. If poor response, then we have to plan for intrastromal injections or interface irrigation with the antibiotic solutions. We can try, and if the good response, we can continue the treatment. If it is poor response, then we have no option to go for the surgical treatment. So medical treatment, fluoroquinolones are the first drug of choice we have to consider, and fortified cephalosporins and aminoglycosides. These drugs will respond because most of the organisms are gram-positive organisms that are affecting the post-PKIK. So in fungal, already we know natamycin, amphotericin B and voriconazole. And early systemic antifungal treatment is needed for in case of fungal PKIK. So in case of recurrent HSV, we need to start the acyclovir, oral acyclovir. Topical steroids are contraindicated, and we can use the substitute drugs like cyclosporins. So intrastromal injections, interface irrigation and antimicrobial agents may use particularly deep-seated infections, and therapeutic corneal cross-linking recently reporting to treat these conditions. So complications are endophthalmitis, graft rejection, corneal perforation, infectious crystalline keratopathy, orbital cellulitis, corneal scarring, persistent epithelial defect, corneal neovascularization, wound dehiscence, and phthisis bulbae. These are the complications. Coming to the conclusion, it is a clinical entity that often poses significant diagnostic and therapeutic challenges. It carries a high risk of serious complications such as graft rejection, failure, and commonly endophthalmitis. So it is most common in the PKP and ALK cases. And broken sutures have to be consistently shown to be a main risk factor for the PKIK. Optimal management of ocular surface diseases such as dry eyes, blepharitis will prevent the infection in the post-PK cases. A stepwise treatment strategy can often be used to successfully treat these cases. These are the references I checked. Thank you very much.
Thank you, Dr. Veena, for elaborative talk. Next speaker would be Dr. Arvind Roy. Presentation, microbiology and treatment outcome of infectious keratitis. Sir, please limit to 7 minutes. All of you, please limit to 7 minutes. Next speaker would be Dr. Nishat Hussain. You be ready with your presentation. Madam, you can come. Dr. Nishat Hussain. Evolving patterns of antibiotic susceptibility in microbial keratitis.
A very good morning to all present. It's working. A very good morning to all present here. I'll be speaking about the evolving patterns of antimicrobial susceptibility in microbial keratitis. And this is the spectrum of the ocular infections which we see in our center. And at 35% keratitis cases are the most common ocular infections which we encounter. And when we speak about the spectrum of pathogens in microbiologically confirmed microbial keratitis, then 56.4% are bacterial and fungal constitute 42%, and then there are others. We also see a lot of mixed infections. Most of the mixed infections are 2 infections in various combinations, and then there are some which are 3 infections as well. We start with bacterial infections. This is the data of 8 years which I am presenting from 2015 to 2022, and we are able to see that in all the years, coagulase negative staphylococci are the most common pathogens, which is followed by Staphylococcus aureus and Pseudomonas aeruginosa. Clearly seen in this pie that coagulase negative staphylococci, they are responsible for 66% of microbiologically confirmed bacterial infections, and Staphylococcus aureus and Pseudomonas aeruginosa, they are responsible for 13% each, and enterobacterials as a group of non-gram negative bacteria, which are including E. coli, Proteus, Klebsiella, etc., they also cause 6% of the infections. We'll start with the resistance pattern of Staphylococcus species, and in this graph we are able to see that first of all, the good news with staphylococcal isolates in our center is that all the isolates are uniformly susceptible to vancomycin. We are able to see that 2 commonly prescribed fluoroquinolones and erythromycin as well as to clindamycin. The resistance is very high in all the years. Good susceptibility is seen against gentamicin, tobramycin and amikacin, which are the aminoglycosides, and also against tetracycline and chloramphenicol. And in case of aminoglycosides, we are also able to see a downward trend over the years, that is increasing susceptibility in the recent years. Also this CX, the first is cefoxetine resistance, which is a surrogate marker of methicillin resistance. So methicillin resistant staphylococci are very less compared, considering that ours is a tertiary care center. 25 to 35% of methicillin resistance is not very high. Coming to the resistance pattern of Pseudomonas aeruginosa. So here the bad thing is that there is no single anti-pseudomonal drug to which all the isolates were susceptible. And we saw that again to the commonly prescribed fluoroquinolones and cephalosporins, the resistance was very high. Good susceptibility was seen against piperacillin, imipenem and polymyxin B, and against polymyxin B again we saw that there was a downward trend in resistance, that is the susceptibility was more in recent years. Coming to enterobacterials. Enterobacterials, although they cause few infections, but we are able to see that they are highly resistant organisms. And especially to penicillins, cephalosporins and fluoroquinolones, the resistance was very high. And against aminoglycosides, tetracyclines and carbapenems, also piperacillin tazobactam, the susceptibility was better. And there was no single drug against enterobacterials also, against which all the isolates were susceptible. So it is important for us that the empirical treatment is based on the current antibiograms, and as much as possible the microbiological investigations should be done before starting any treatment, and the treatment protocol should be modified as per the microbiological reports. In fungal infections, this is the spectrum. Aspergillus as a single genus is the most common pathogen, followed by Fusarium. Also Dematiaceous fungi or the pigmented fungi as a group, they cause a lot of infections, and then there are others like Penicillium, Poecilomyces, Acremonium, Candida, etc. This is a study done in 2019-20 where we were able to see that our Aspergillus isolates, they showed good MICs, very low MICs against the azole group of voriconazole, itraconazole and posaconazole antifungals, whereas our Fusarium isolates, they were showing lower MICs against netamycin. Also, the point of concern was against fluconazole and caspofungin and micafungin, there was absolute resistance. Similar study done in 2021-22 showed same results. Aspergillus species showing lower MICs against voriconazole, itraconazole and posaconazole, and Fusarium species more susceptible to natamycin. We did AFS antifungal susceptibility testing of yeasts also, and we found that Candida, which is the most common yeast, was susceptible to almost all the antifungals which are commonly prescribed. Rhodotorula, which is an emerging yeast infection, it was susceptible only to voriconazole, itraconazole and posaconazole. Also Axiophala species, we have reported one case. This is a rare black yeast. It shows good susceptibility to voriconazole, itraconazole and posaconazole. So we should keep in mind that geographical variations are very common in fungal agents. So the empirical treatment should be guided by local epidemiology as far as possible. And in case of refractory diseases, refractory cases, we should do antifungal susceptibility. So I acknowledge the hard work of all the 3 cornea units and also the ocular microbiology team in management of the keratitis cases in our center. Thank you for your kind attention.
Thank you, doctor. Whatever your experience regarding imipenem and meropenem?
Imipenem and meropenem are actually very good for enterobacterials and pseudomonas. For pseudomonas, we prefer meropenem, and for this, but it has to be given only in cases which are resistant to all other antimicrobials, because they are the last drugs.
It is as a last resort.
Susceptibility is quite high in these cases.
Thank you.
Thank you very much.
I request Dr. Arvind Roy. Presentation, microbiology and treatment outcomes of infectious scleritis.
Thank you, madam, and thank you to the organizers for the opportunity to present our work. Microbial keratitis is reaching epidemic proportions in the Southeast Asian nations, and this map shows where most of the cornea blind worldwide live. So again, as not very unexpected, most of them are in Southeast Asia and in Africa, sub-Saharan Africa especially. So these are some of the statistics that shows the country reports where India is still quite high, and about 840,000 new cases of corneal ulcers occur each year. However, there has been a demographic shift that we are seeing. This was a paper that we published after COVID, that the health seeking behavior of patients have changed. More and more patients are treated adequately and appropriately at the community level. And when they reach the tertiary centers, part of the treatment has already finished over there. This is in contrast to the papers which were a decade earlier, where almost a third of the patients did not have a appropriate or a rational antibiotic combination with them. So there are 2 approaches to treating microbial keratitis. One is the empirical approach, which many follow because of the lack of a proper microbiology support, and the other is a case-based smear approach. And as we have also discussed time and again, that a systematic way of examining the smears are to have a gram and KOH and cultures, solid and liquid media, and PCR analysis for the identification of particular DNA. This is important because liquid media will detect any small quantities of organisms. PCR is very sensitive, it will detect any DNA that is present. And as an extension, there has been many microbiological advances. Madam here will also agree with that. We have access to Vitec, where we perform the card-based diagnosis, and it's again a very sensitive test. MALDI-TOF, mass spectroscopy based analysis, next generation sequencing, which gives us heat maps of all the DNA that is there. This need not be disease causing DNA, but all the DNA that is present in the sample, and one can get access of the variety that is there on the cornea. What else is interesting in the diagnosis and approach is to have an ASOCT, which can provide details of the areas of necrosis, post corneal plaques, retrocorneal plaques, cellularity, areas of melting. IVCM has been in vogue, but it is an expensive equipment. It is very sensitive. The IVCM images are those of fungi, where we see that these are fine branching filamentous tubule-like structures, and they are 3 to 8 microns. Very, very specific once we get it, but sensitivity is operator dependent. That means that some training is required before we can diagnose a deep lesion and label it as fungi. So also for the acanthamoeba, and bacteria cannot and virus are not caught by the IVCM. Then what's coming, what is of interest is the convoluted neural network, artificial intelligence, machine learning. This is something which is exciting and new that is happening in microbial keratitis. Different groups are studying this, and there is 3 components to this. First, find a artificial intelligence system. Many of them are open source. This is a very lay breakdown from an ophthalmologist point of view. Second, put in a set of pictures which is typical to our own practice, our own demographics, and then train the AI. Tell them which is keratitis, which is scar, for example, if we break it up, and then validate it by showing the test pictures. So this is what the experiments are these days in AI, and there are different AIs that are available, but what is commonly used is the DenseNet and the ResNet. So these are the 2 AIs that, I'm sorry for the small print that is there, but these are the commonly used AIs that are used in ophthalmic practice for keratitis discrimination. From the treatment aspect, again we always rely on newer molecules, but we need to understand that there are many other antimicrobial products that are there. These are, such as example, are antimicrobial peptides. Currently we are in collaboration with University of Sheffield developing an antimicrobial peptide for use in microbial keratitis. Intrastromal injections continue to be important, and yeah, so it involves using a bolus drug, typically antifungal, which is injected up to the mid-stromal level, and a barrage is created around a deep lesion inside the corneal stroma. So there are reports which say that this is helpful. There are reports which say that this is not helpful. So it's a mixed bag, but it's always good to understand this technique and deploy it, use it when required. It works. It works. Sometimes it doesn't work, but nonetheless. So that's the barrage that is being performed. So a detail on this will be beyond the scope of the current topic. So I'll just give you an overview of what are the strategies that we have evolved. The second is the collagen cross-linking. Now, very good studies have found that collagen cross-linking is not very effective, especially so in the setting of fungal keratitis. What's interesting is the rose bengal. The rose bengal is showing a lot of promise, rose bengal photodynamic therapy. And in the field of antimicrobial resistance, we have an excellent talk now. What we also found is that not a lot of protocols are available worldwide, and this is because of lack of monitoring and lack of proper antibiotic stewardship. In summary, it's important to make a diagnosis, manage it scientifically, interpret, deploy newer modalities for accurate diagnosis. Thank you very much for your patience here.
Thank you, Dr. Arvind Roy. Next speaker, Dr. Partha Biswas sir. Please comment to the new paradigm in management of evaporative oil.
C-type connector.
I think no other speakers are there. This would be the last step. Thank you, sir. Thank you. Nice meeting.
Before you go, Arvind, it was a very nice talk.
Thank you, Doctor. Made my day.
Right. So cornea has to come in somewhere with dry eye. And so this is the last talk of the session, and the dry eye management, the newer options that have come in is something that is important, something that we all should understand, because we day in and day out lead and treat the conditions of the eye, at times forgetting that we also need to treat dry eye. And how common is it in India is what is a stark reality. 32% of overall prevalence of dry eye. That's a huge number, and most people have this moderate to severe dry eye. And you can see that there is a 61% of moderate dry eye. When it becomes severe, then we are forced to treat. But when we should start treating is when it is mild to moderate. And if we do the tests of the prevalence, then it's a near 82%, and the prevalence of dry eye when these objective tests are used is again a very important aspect. And this is where we have to term that there's a hidden epidemic of dry eye in the world today, especially in India, and frequently overlooked and underdiagnosed unless it becomes a distressing problem. So the tear dynamics, of course, let us quickly go through the tear dynamics with a focus on the lipid layer and the tear film layers. As we know, the air and the air lipid interface, the lipid layer itself, the polar lipid layer, and then comes the lipid water interface, and then the aqueous layer, and of course the glycocalyx layer. So the corneal epithelium has the protection of all these layers, and when one or both are affected, then it becomes either the aqueous deficiency dry eye or the evaporative dry eye. And at times, in the majority of the cases, the dry eye is evaporative, and which is characterized by the meibomian gland dysfunction. So the evaporative dry eye is the commonest mode of dry eye, and the risk factors are these. The MGD has actually been found out that it is one of the most difficult diseases to treat and one of the most commonest. And the MGD has to be treated. The ocular surface related dry eyes are there. Also, the systemic disorders do contribute, of course, to a smaller subset, but there are others as well, and the lid disorders, the Parkinson's, and the contact lens wearers. Also is the post-refractive surgery patients who are at risk with dry eye. So how do we make up the goals of the dry eye? So it's first to relieve the symptoms, because the patient comes in time and again, insistently and persistently saying that he has a problem, and to a general ophthalmologist at times seems that he is just making too much of something that is not there. But let's remember that if a patient comes insistently and persistently, there is a problem, and most of them have this dry eye problem, which is a difficult problem. So we have to prevent the corneal damage, and if we don't treat it well and in time, the corneal damage can occur. The ocular comfort of the patient is very important, and especially we had the World Sight Day, and we all thought about the eye health at our workplace, and this is where the workplace scenario is changing because of consistent uses of monitors, not only in the urban region but also in the rural regions, and this is getting more and more difficult to treat dry eyes. So the ocular surface and the tear film to a normal status is required. The DUCE 2 has put in these steps of 1, 2, 3 and 4, and the treatment is based on the tear film layer that is affected. So the lipid layer, the aqueous, the epithelium and the ocular surface, and if we go in, then the lipid layer treatment, the warm compress and the lid hygiene, though it's a very small type of treatment, but it is a very important treatment. The aqueous and the mucus layer, Here, of course, we have the aqueous components and the artificial tears, sodium hyaluronate, and the rest come in the punctal plug, which can actually be dispensed by the common ophthalmologist, by the comprehensive ophthalmologist, is not so much done, which it should be. Again, the epithelium, and here again the autologous serum and the rebapamide is coming up as an important aspect. The inflammation has to be identified, and ocular surface inflammation, if it is there, cyclosporin and steroids have to come in. So these are the, but where are we at the artificial tear paradigm? And the availability of the artificial tears, and the artificial tears are improving in their function when the artificial tears do not work, when the aqueous artificial tears do not work. That's in the lipid dysfunction or in the inflammation, and the treatment should go beyond the artificial tears in these conditions. So it's important to understand where the lipid versus the aqueous artificial tears have to be there. And here comes the importance of the emollient and the lipid-based artificial tears. So the emollient eye drops have been developed. They have been developed by certain companies. I do not have proprietary interests in the financial interests in this. However, the talk is sponsored by Alcon. And I have to say that the lipid layer normally ensures that it reduces the aqueous evaporation by 90 to 95% and reduces the surface tension by 25%. So there was a very nice study which looked into the nano-emulsification, emulsion eye drops versus the non-emollient eye drops. And what it really did prove is the nano-emulsion eye drops does increase the lipid layer thickness and improves the OSDI. So who is going to benefit from this lipid-based eye drop? It's of course the mild to moderate aqueous deficient and the evaporative cases, and predominantly the evaporative dry eye patients. I'll just take one more minute. Management is of the evaporative dry eye. We have the protocols in place very well, and the benefits of the lipid layer, lipid-based eye drops is important, and it does help to come a step to the natural tears, longer lubricating, and of course we cannot, as dry eye patients, we ourselves will not be able to put in the eye drops very frequently. We want eye drops that are going to suffice for our work environment, at least for 8 to 6 hours. And so which one? And these formulations have come in, and this is a particular formulation with the key ingredients of nano-sized lipid droplets, which has come in, and which is something which is very important. It also has the PEG and the HP-GUAR, which increases the mucus layer thickness, and thus this particular eye drop does have a big promise, and it is working very well to improve. So in conclusion, the dry eye is a common situation. It considerably affects and badly affects the daily life of the patient. 4 out of 5 cases of dry eye are evaporative dry eye, and the deficiency of the lipid layer in the tear film is what the evaporative dry eye is because of. And the artificial tears, which are effective in evaporative dry eye, mimic the natural tears and replenish the lipids. Nano-emulsion formulations are definitely important. Thank you very much for your patient hearing.
Thank you very much, sir. And thank you all speakers.
Thank you. So before we leave our seats, I would just like to have a quick raise of hands. How many of you in this very small audience feel that the format of the midterm conference has benefits? 3. Yeah, it can be a very, very, honest show. Thank you very much. And do you think the case-based scenarios are more important, the faculty talks are more important than the structured symposium of ICs and the rest? Or Do you think the case-based scenarios have a particular amount of importance in our midterm conference? In fact, that is the reason why when we started the midterm conference, the case-based scenarios took an upper hand, and we coupled it up with the faculty talks so that it becomes more interesting, more practical in the sense, whereas the annual conference, of course, has a very, very structured program. Thank you very much. Thank you, madam.